Hello, everyone, and welcome to the second webinar in our 2020 webinar series titled SOAR and Criminal Justice System Implementation. My name is Pam Hine, Senior Project Associate with the SOAR TA Center, and I will be your moderator today. Before we begin, just a few housekeeping items to review. A quick disclaimer. This training is supported by the Substance Abuse and Mental Health Services Administration, SAMHSA, and the U.S. Department of Health and Human Services. The contents of this presentation do not necessarily reflect the views or policies of SAMHSA or DHHS. The training should not be considered substitutes for individualized care and treatment decisions. A few webinar instructions. As a reminder, your lines will be muted throughout the entire webinar. This webinar is being recorded and will be available for download on the SOAR website soon after. You may download the presentation slides and other materials now by going to the top left of your screen and clicking File, then Save, then Document, or visit the SOAR website at soarworks.prainc.com, click Webinars on the left sidebar, and choose today's topic. At the conclusion of the webinar, you will be asked to complete a brief evaluation, which we kindly ask you to complete. And finally, we will save all questions and comments until the end of the presentations, at which time we will review instructions for posing questions to panelists via the Q&A box. So it is our intentions that by the end of this webinar, you will be able to discuss the connection between serious mental illness, homelessness, and incarceration, review the impact of incarceration for SSI, SSDI beneficiaries, and review key strategies for introducing SOAR to and engaging the criminal justice systems. You'll also learn SOAR best practices for assisting SSI, SSDI applicants who are involved in the criminal justice system. And we'll discuss successful SOAR implementation from a management and also a case manager perspective. Okay, one second. Okay. Oops, sorry about that. Okay, so just to review our agenda. To reach those objectives, we will begin this afternoon with presentations from Dazar Aware, Senior Project Associate with the SOAR TA Center, and our subject matter expert on SOAR implementation within the criminal justice system. You'll then hear from Deborah Dunham, who is the Community Integration Coordinator and also a SOAR local lead with the California Department of State Hospitals, Coalinga, in Coalinga, California. Also with us is Michelle Cadu, who is a SOAR specialist with the Kansas Department of Corrections in Topeka, Kansas. We were hoping to have Amy Dean Campire, who is also with the Kansas Department of Corrections, who is a SOAR local lead. Unfortunately, she was pulled away for an emergency meeting, so we just want to thank her also for creating her presentation. We're hoping to have her at the very end of today's webinar to be able to answer some of your questions. So we're hoping to have Amy with us at that time. So to do our welcome today, we have Asha Stanley, who is the SOAR TA Center Project Officer, who will do our brief welcome.
Thank you, Pam. On behalf of SAMHSA and the Division of Community Systems Development, the Center for Mental Health Services, I would like to welcome you to this SOAR webinar titled SOAR and Criminal Justice System Implementation. As many of you know, SOAR helps states and communities increase access to Social Security disability benefits for eligible adults and children who are experiencing or at risk of homelessness and have a serious mental illness, medical impairment, or co-occurring substance use disorder. For many years, SAMHSA SOAR TA Center has been helping local corrections and community transition staff integrate benefit options with community reentry strategies to promote post-release success. We have learned that increased use of the SOAR model as a tool for reentry services leads to income, to access housing and insurance, to access treatment and programs. Today's webinar will give you practical and proven ideas to help you better understand how to implement the SOAR model within your criminal justice system. I would like to welcome and thank our presenters for your willingness to share your expertise with us. I will hand it back over to Pam Hain, who will be moderating today's webinar.
Thank you, Asha. I will now turn the mic over to Dasra Aware, who will kick things off. Dasra, you may begin your presentation.
Can you hear me okay? Just wanted to check.
Yes, we can hear you just fine. Yes.
All right, perfect. Well, thank you, Pam, for that wonderful introduction, and thank you, Asha, for that warm welcome. And thanks to you all as guests for taking the time to participate in this webinar today. We're very excited to have you here. I apologize in advance for the scratchiness sound of my voice this afternoon. I'm a remote employee, and I'm located here in Metro Atlanta. And the pollen here today is a little disrespectful, so please bear with me. I will try my best to speak clearly, but if you are having trouble hearing me, just let us know. As Pam mentioned, this webinar is entitled SOAR and Criminal Justice Implementation. Please keep in mind that I will refer to the criminal justice system as the legal system throughout the webinar, as we are hoping to promote benefits acquisition to more than just those that are eligible applicants that reside inside the confines of prisons and jails, but also to those that are participants in reentry programs, those that are under supervision of probation and parole, participants of mental health courts, or newly released individuals returning to communities that are experiencing or at risk of homelessness. This webinar will explore the intersection of the legal system and behavioral health and how the SOAR model can be used in the effort to address the challenges associated with reentry and recovery for people with serious mental illness, physical disabilities, co-occurring substance use disorders. I'll also briefly review what happens to SSI and SSDI benefits when a recipient becomes incarcerated, and then I'll just kind of hand it over to our special guests to hear from them about the best practices for increasing access to these benefits for eligible individuals from both that management and caseworkers' perspective that Pam spoke of. So to start off, let's just start by defining identifying what SOAR is. So for those guests that have experience providing SOAR assistance, please use this time as a refresher as I quickly review some key points for other participants that might not be as familiar. To start, SOAR stands for SSI, SSDI Outreach and Recovery, and this is a model that's sponsored by SAMHSA in collaboration with the Social Security Administration. It was developed to assist eligible individuals to apply for the 2 disability programs that are administered by the Social Security Administration, SSI, which is the Supplemental Security Income, and SSDI, Social Security Disability Insurance. This model was specifically designed to help states increase the access to these benefits for those that are experiencing or at risk of homelessness and have serious mental illness, medical impairments, or co-occurring substance use disorder. It's used in all 50 states and Washington, D.C., but it's also important to note, however, that although SOAR presence is marked nationwide, there are many communities within each state that may not have SOAR providers just yet. We are really working very hard here at the SOAR TA Center to expand SOAR efforts to the point where every community, everywhere, in every state will gain access to SOAR providers in the future. That was the kind of general information about SOAR, and we'll now look at what makes SOAR unique as a model. First, it's important to keep in mind that the SOAR model is a model that's intended to expedite the determination process by providing information needed so that SSA decision makers are equipped to make those decisions faster because they have everything that they need in order to do so. So SOAR providers make SOAR work. I can't make it any plainer than that, because they produce the strong, complete, concise applications that help DDS to make these decisions without having to request and wait for information after the application has been submitted, because the SOAR providers include that information on the front end. So remember that SOAR is a model that encourages collaboration. It facilitates communication among applicants, case managers, SSA, DDS, and community providers, and it prepares case managers to assume the central role of gathering complete, targeted, and relevant information for SSA and DDS to use. And lastly, as this slide points out, SOAR operates on the use of what we call critical components that are unique to the model. So this slide represents the 5 components, starting with what we call the SSA 1696, or the Appointment of Representative form, which is that form that really allows for that two-way communication between the SOAR provider, SSA, and DDS. It allows the SOAR provider to not only give information to SSA and DDS, but also to get information from them and to ask questions if the application is complete. Did they miss any information? Is there anything else that they need that they can assist with? We also encourage the collection of medical records. And this way, DDS won't have to use their time to collect those records, request them, wait for them to come back, which increases the time to decision. So when SOAR providers collect those medical records and have them available as part of the complete packet, that is considered a critical component as well. Writing and submitting a medical summary report is really about providing that information that's not readily available in medical records, which speaks to how that person functions. The medical records do a great job of identifying that medical condition, but it doesn't always speak to how, in spite of that medical condition, that person is unable to function. So that medical summary report, we spend a lot of time on training SOAR providers around the country to understand the importance and the relevance and the material that's needed in medical summary reports to meet that second portion of what's necessary to make a decision. The 4th component is obtaining a co-signature for a medical summary report, which involves, again, I'll say that word collaboration a lot, because SOAR is built on collaborative efforts. So collaborating with those community providers or those medical treatment sources that provide services and medical treatment to the applicant, getting those persons to co-sign on the medical summary report that the SOAR provider writes to bump that information up to full-fledged medical evidence is a critical component. And then finally, completing a quality review for applications before submitting to Social Security is also paramount. Completing a quality review is meant to ensure that the information submitted is complete and concise and stands up to the fidelity of the SOAR model. Now, all of these things help the determination process move more smoothly and quickly by providing the assistance to Social Security and DDS that they need. SOAR seeks approvals on initial applications, so we try our best to avoid the need for appeals. And we also really like to implement and stress the importance of the importance of work to increase access to supportive services and employment opportunities even after decision. So with all of that of what's included with the critical components, understand that this kind of model is thoroughly supported. We have a SOAR leadership structure that's unmatched by many other models. The SOAR TA Center is comprised of 9 teammates, many of which have past experience as SOAR providers. We've done applications. We are dedicated to developing the tools, facilitating trainings, providing guidance and technical support to agencies and communities, and to individuals that are seeking SOAR assistance as well. We welcome any opportunity to serve you in this way, and we are approachable and reachable and available to help you in any way that we can. And part of our responsibility is not only to give continued support, but to also make sure that the state and local leaders are supported. And these state and local leads spearhead and coordinate the implementation of the SOAR initiatives. These leaders identify and engage with stakeholders to participate in steering committees that meet regularly to collaborate and report on progress. They troubleshoot challenges reported by SOAR providers and basically provide that continued support for SOAR case managers with supplemental trainings and online course support. All of these players are valuable key partners in the SOAR initiative. We are all united to end homelessness and increase post-release success for individuals with disabling conditions. However, I have to point out that the case managers are the SOAR wings of the structure because they work hard to provide the highest quality applications, and without applications, SOAR would not soar very far. So those case managers are what we really depend on to provide the direct services to the individuals that need it the most, and training them to use all those critical components that we mentioned in order to yield the best results for individuals that they serve. And the use of those critical components really help to amplify our outcomes. So we're looking at now cumulative outcomes reported by 50 states and Washington, D.C. for last fiscal year. The outcomes reflect a 65% approval rate, representing 43,486 people that have been approved for SSI or SSDI upon initial application since SOAR began. An additional 6,591 people whose applications were denied initially were approved on reconsideration at an ALJ hearing using the SOAR model. So taken together since 2006, the SOAR approach is responsible for assisting over 50,000 people who are experiencing or at risk of homelessness to access Social Security benefits, and that's quite remarkable. And so to look even closer, we'll look at the 2019 outcomes. This slide reflects the initial application outcomes reported by SOAR providers for annual reporting period that started last year, July 1st, 2018 to June 30th of 2019. I'll take a pause to remind you all, SOAR providers out there, we're really close to the end of this reporting period, so be aware that we're going to be starting to ask for those outcomes because June 30th will happen faster than you think. But with regard to 2019, there is a 63% approval rate on initial applications at 108 days to decision with 4,273 approvals. That's a lot of lives that are changed. These outcomes can be compared to the national average of about 29% for all people applying without assistance. Now, I don't know about you, but when I first started this SOAR journey, I was convinced that denials were required before a person could be awarded benefits. And that, under my, thought then, I believe that, it took about 4,000 to 6,000 times that a person had to reapply before they actually were approved. So I'm here to chant the old cliche that knowledge is power that brings forth change. Once you know what is needed in the process and what is necessary for someone to be approved, your approach to applying is forever changed. So, with knowing that, it's important to understand what Social Security's definition of disability is. How do we identify an individual that could be eligible for Social Security benefits? So the Social Security Administration defines disability as the inability to engage in substantial gainful activity or work activity for pay or profit with earnings of $1,260 a month for this year because of their medically determinable physical and mental impairment that has lasted or expected to last for a continuous period of at least 12 months or more, or expected to result in death. And gainful is identified as work activity for pay or profit, even if that profit is not realized, and earnings is a reflection of a monetary amount of $1,260 a month in 2020, and that's up from about $40 from last year, where it was $40 less than that. So now that we understand that definition and what Social Security is looking for, let's look closer at the two disability programs. So there are two programs that are administered by the Social Security Administration. Both have similarities, and we'll talk about them, but both have some significant differences. We'll start with the similarities. So both programs have the same criteria for determining disability based on the medical evidence and the functional limitations. And both programs utilize the same application process, though they have different application forms. They share one disability determination. Each program has an associated health insurance program. So on the left of the screen is Supplemental Security Income, which is SSI. That's that needs-based program. It's for individuals who are blind, disabled, elderly, low to no income or resource sources. The federal benefit rate, which is the maximum amount awarded with federal dollars when approved, is $783 a month, and this program is accompanied by Medicaid in most states. And again, this is a needs-based program. Resources are going to be considered, and if you have resources, in short, if the application has other resources, they don't necessarily need it, and they will not get SSI. Now, on the other hand, or should I say on the right side of the slide, is SSDI, which is Social Security Disability Insurance. It's also for blind or disabled individuals, but these individuals are insured through contributions to the Social Security Trust Fund. This is the work-based program, so the amount of contributions that the individual deposited while working will yield will yield the award amount if the person became disabled. So the amount of money they put in is what they'll get out if they became disabled. And in most states, Medicare is the health insurance that generally is provided under this program. So again, these are both disability programs that require an applicant to meet the same Social Security definition of disability. So why is this important for people that are involved in the legal system? What does SOAR have to do with any of this? Oh, I'm so glad you asked. So with all of this knowledge, SOAR is important for so many reasons for people involved in the legal system. First off, people with mental illness remain in jail 8 times longer at a cost that's 7 times higher. There are at least 3/4 of incarcerated individuals with mental illness have co-occurring substance use disorders, and 20% of those incarcerated with mental illness have experienced homelessness in the months before their incarceration compared to the general population. But even before I continue to recite all the various other reasons that SOAR should be considered as part of reentry planning and implementation by agencies or facilities that provide services to them, just know that these people are coming back to communities. Healthier people in communities, healthier people make healthier communities. And we can't overlook the numbers. We can't overlook them anymore. And I think that it's also a good time at this point to just kind of let you know a little bit about my background. So in my previous life, I worked in the legal system, both as a police officer and later as a counselor in the Georgia Department of Corrections. And after that, I was a program director for an organization that provided services to people that were often subject to arrest because they had nowhere to go because they couldn't work. So for just shy of about 18 years cumulatively, I have seen even back then the synergy between mental illness, incarceration, and homelessness and how intertwined they are. The intersection of the legal system and mental illness makes the road to experiencing homelessness a likely destination for people that exit facilities without supports in place. And, you know, the numbers are staggering. So we are talking about a lot of people that are going to be released and returning to communities. This is a slide that was presented by the Prison Policy Institute, and the number of incarcerated people has reached well into the 2 million mark nationwide. And these folks, again, are going to be released. Why not provide the tools that they need to help a healthier transition into community living? In 2016, SAMHSA estimated that about 10.4 million adults in the United States had a serious mental illness. But according to the Bureau of Prisons, which oversees a little under 200,000 individuals as of May 2017, 4% of those incarcerated individuals had a serious mental illness. Now, whether you're leaning toward more that number is higher, there's so much debate around that actual number, and I don't even know if that number is important. The number, the percentage amount in comparison to the amount of people that are incarcerated, no matter what the number is, still suggests that there's a significant amount of individuals that are going to be integrated into communities that are in need of the tools that they need to make post-release a success. And the most vulnerable of that population are people that experience mental illness. So the prevalence of people that are in state and federal prison with mental illness can no longer be overlooked. And attention needs to be given to this section of our society. With regard to homelessness, nearly 550,000 people a year into shelters directly after release from correctional facilities. And people with serious mental illness are more likely to be arrested more, spend more time in jail, have longer sentences, and have higher recidivism rates than those without mental illness. So again, even at 4%, the number of incarcerated individuals is not only significant, but it's deserving of the resources that they need to promote post-release success. Because eventually, again, they will return to communities, and how they return is up to the people that provide their care. And so using SOAR as a tool to help with that transition is one of those things that we hope to promote just even through this webinar. And with that, you know, when we think about the sequential intercept model, there's an opportunity to infuse SOAR in all the areas of the sequential intercept model. From Intercept 1, by addressing the needs of individuals before legal involvement, by acknowledging the likelihood of their police interaction due to the behaviors expressed that can be directly linked to the symptoms of their diagnosis and the vulnerability of people with serious mental illness that are experiencing homelessness, to the collaboration with law enforcement and community providers that establish plans to address the needs of individuals with serious mental illness and provide them with services rather than arrest, as many law enforcement and emergency agencies have limited alternatives outside of arrest, to initial detention and court hearings to offer support rather than confinement, to implementation of SOAR practices to submit applications so that the applicant can receive a decision before discharge and return to communities with benefits in place, to developing strategies for that warm handoff for applicants, for applications that may have been submitted while the applicant was in custody but released before that decision was realized, so that the proper follow-through is established so that applicant and that application does not fall through the cracks soon after the person is released from custody. Excuse me. All these measures are needed to establish a foundation for recovery, resilience, and reentry success. Every single one of them. I want to emphasize that the housing is a strong factor in post-release success. and it promotes participation in treatment. The insurance is important, but you can't sleep in it. Health insurance and treatment become secondary to the hierarchy of needs for newly released individuals, or anyone for that matter, that faces housing insecurity. It's hard to think about treatment when your basic needs aren't met. The use of SOAR can secure funding that can promote housing stability that is desperately needed, and ultimately used to increase treatment participation and decrease the utilization of hospitals and emergency rooms for care. I'm hoping that you all are thinking the same thing that I was thinking back in those days of old when I first learned about SOAR, you know, those good old days when TP and paper towels were aplenty. You know, how can this work? Why isn't everybody doing SOAR if this works? So I'm not able to change this slide, Pam. Okay. So you know, why isn't everybody working to see this? Why isn't everybody doing this? Because we're not addressing the elephant in the room. We're just simply not. I want to emphasize that, you know, we can't do this alone. This is a collaborative effort, and we just can't do it alone. Collaboration is the cornerstone to SOAR success. Partnering with medical records, community mental health, sheltering agencies, housing partners, hospitals, court systems, probation, parole. Why? Why do we need to collaborate with them? Because partnerships and collaborations are critical to any reentry program success, because we share the same clientele and we often provide the same services to the exact same people, and then we still say we don't have the money. It's imperative that we work together to strategize ways to share information, jointly develop funding strategies, and organize our efforts to assist individuals with tools that they need upon release in order to reduce the likelihood of their return to the legal system. And here are some facilities that are right on their way to SOAR success. Since 2017, 18 agencies have responded to the call and are working to implement SOAR within their programs by applying for and receiving what we offered as the SOAR Technical Assistance Award to strategize a plan for SOAR implementation in their facilities. These organizations understood the urgency to connect with people they serve with the resources they needed to promote reentry success into their communities as they transition into the communities. They worked through delays in implementation due to staff changes and leadership changes, limited resources, workload demands, and they are using the outcomes as leverage for funding conversations because the data can no longer be overlooked. The need for SOAR implementation is critical for reentry efforts. I know I've said that multiple times already, but I can't emphasize it enough. The challenges faced by reentry planners, case managers, court systems, probation, parole officers, and others responsible for assisting individuals comply with the conditions of release while they're still looking for resources to meet basic needs such as housing and treatment is exceptionally challenging when the individual has no income, no support, and is likely to is not likely to maintain employment because of their disabling condition. However, our outcomes can instill hope. This report was generated on March 6th of this year. It's for SOAR-assisted SSI, SSDI applications that have been completed for people living in correctional facilities, resulting in about 73% approval rate and an average of 86 days. So although these outcomes are strong, our goal is to see more people that are currently incarcerated or involved in the legal system in some way to have access to SOAR services. because we are confident that benefit acquisition for eligible people that are exiting legal systems can surely promote post-release success. The possibilities of the equation speak louder and clearer every day, but still, SOAR is an underutilized reentry tool. With almost 2.5 million people, we have 445 cumulative total SOAR-assisted applications. That's just not enough. For eligible individuals, benefits acquisition increase access to income and health insurance and promotes successful reentry. Income equals access to housing security. Insurance equals access to treatment. Housing plus treatment equals a reduction of recidivism. The reduction of recidivism equals the reduction of the financial burden to states, counties, and agencies. The equation is there. The tools are available. I really hope that this information inspires you to want to take back to your communities and at least try. But where do you start? How do we get started? Well, the first thing is to start off that believing that recovery is possible and approaching SOAR implementation from a solutions-based perspective. Benefits acquisition may not solve every single issue, but it is a start to alleviate some of them. Then consider a pilot. Stick with the plan, give yourself some time to see results, practice, repeat. There are tons of resources that the Social Security Administration has to assist with information to support applicants that are currently incarcerated or newly released to apply for benefits, and to clarify some of the misconceptions that people with legal histories and staff that work with them may have about benefits acquisitions for that population. In collaboration with SSA, the SOAR TA Center has worked hard to debunk many of the myths associated with legal involvement and applying for disability benefits. It's important to note that that people that are incarcerated are still citizens. They're citizens that can still be afforded the resources and the benefits of benefit acquisition. People can apply for benefits while they're incarcerated. Prior history of incarceration alone does not make someone eligible or ineligible for benefits. And warrant other than escape should not hinder a person from applying or receiving payment. Establishing, and we'll talk a little bit about this later on, I'm sure our special guest will speak on this as well, but establishing agreements between the agency and the local Social Security offices can also help to increase the likelihood of receiving a disability decision before a person is discharged from confinement by establishing what's called a pre-release agreement. So with those agreements, new applications can be made prior to the person's release, and as a general rule, this happens around at least 30 days prior to the expected release date, and that's a general rule. That's what happens when there is no pre-release agreement in place. It's a general Social Security rule. But pre-release agreements between SSA and the institution can be extended as many as 120 days prior to release. And so with the average day of decision being 108 days, extending the days to the earliest time possible that an application can be submitted to Social Security increases the likelihood that a decision is made before discharge. I hope that we can find funding to get those on T-shirts, because that's the ultimate goal, and I will wear that T-shirt proudly. But what happens to a person that already had benefits before they became incarcerated? Well, in general, that depends on the type of benefit program the person was awarded and the length of time of confinement. We'll look at that quickly. So for individuals that received SSI, or that supplemental security income, there is no effect on their benefit if they are incarcerated for less than a calendar month. However, if benefits are suspended if the person is incarcerated for 1 to 12 months, and they are terminated when the person is incarcerated for 12 months or more. Be mindful that these are calendar months. There's a difference. It's totally different than just 30 days. For example, if someone became incarcerated on February 7th and released on February 27th, that person was clearly incarcerated for more than 30 days, but not a full calendar month in February or March, so there should be no effect in their benefit check. When benefits are terminated, they must reapply with a new application. For SSDI, it looks a little different. Recipients are eligible to continue receiving their benefits until they're convicted and confined for more than 30 continuous days. Once released, benefits can be reinstated by the Social Security office. They must have their discharge papers to show that they are legally in the community, and they can move forward. And as you continue to speak on your SOAR model, when you go back to your communities and think of, as you continue to think about this, it's really important to have these basic rules in mind. It will help you plan your course of action for discharge planners and reentry specialists and others to prepare for an individual to be released. In addition, paying close attention to the time someone had benefits and what type of benefits they had prior to incarceration is so important because it can save time. Having that information on the front end at intake, when everybody says reentry begins at intake, having that information on the front end could really save you time. It would prevent so many SOAR providers that are helping with this effort to not invest the time with someone that's receiving SSDI, that had received SSDI in the past and hadn't been convicted and they're sitting in jail, from doing a full and complete application because they wouldn't need to. But having that information on the front end is so important. Decision before discharge, of course, I'm going to say it again, is the goal for SOAR implementation in criminal justice settings. Being able to discharge from a facility with the access to income and insurance gives access to the housing opportunities and promotes the likelihood of engaging in treatment. And it's just a win-win for everybody. So now that we've covered the basics with a really broad stroke, I'd like to remind you that you have tons of support here to help you and to help you to develop your implementation plan. We have tons of resources. The SOAR TA Center is always available. We invite you to review these products and tools and resources. Visit our website that contain information that is specific to working with people that are involved in the legal system. Access our online course. It's available to you also, and it's free. I don't know if I've mentioned that, but it is super free, and anything that's free has to be a good thing. In the latest addition to the resources, most recently we've included an issue brief that is accompanied by an infographic that is full of information that is useful to you as you can consider SOAR work in your facility. There's a issue brief. The issue brief is about 11 pages. That's why we have an accompaniment for you. It includes information that we covered during this portion of the webinar, as well as additional examples of SOAR implementation success within state prisons, jails, community, and other community partners. There is also a two pages of information about steps to successful implementation. We invite you to take a look. So before I end my portion of the presentation, and I know that I talked a lot, and I hope that with all that was said, you can hear my commitment to spreading SOAR word to address the needs of the people that are residing in facilities. I want to also remind you of the acronym of the SOAR model that we spoke of at the beginning of the presentation. We said that the official SOAR acronym stands for SSI, SSDI, Outreach, Access, and Recovery. However, for many other people that are involved in the legal system, SOAR also stands for SSI, SSDI, opportunities to access resources for reentry success. SOAR can absolutely contribute to the foundation of reentry plans to succeed and provide the people we serve with the tools they need to make recovery a reality. I invite you to join us in that effort. And now I'll go ahead and end my portion of the presentation, and I will pass the presentation along to my colleague, Deborah Dunham. Deborah is a seasoned social worker and a criminal justice professional and a community integration coordinator, as well as the SOAR CJ lead for the Department of State Hospitals in Coalinga in the social work department. Thank you for having me. All right, Deb.
Hi, Deb. You may want to unmute your line if you haven't already done so we can hear your presentation.
Hello, good afternoon. Can you hear me now?
Yes, we can.
Okay, wonderful. Thank you, Dazra, and thank you to SAMHSA and the SOAR TA Center for the opportunity to share our experiences here at the Department of State Hospitals, Coalinga. Our social work department implemented a pilot program of the SOAR model almost a year ago, April 18th last year. And I'm going to share a little bit about that experience and the population that we serve and how it's benefited our patients. So at our facility, our state hospital discharge planning process flow, as for many in criminal justice, forensic hospital settings, as Dazra mentioned, takes place at the time of intake or admission. And we pay very close attention to what life was like for the individual prior to entering the criminal justice system. What were their challenges? What was their housing? What benefits, what services, resources, et cetera, were needed? Because that's a very good gauge of likely what they're going to need or will quickly return to and then need at the time of discharge without supportive services. So that discharge planning process flows throughout the patient's stay. We serve two patient populations here. California's offenders with a mental disorder is a little less than a third of our 1,200 patients, and the other patient population are those committed under California's sexually violent predator law. So they work on their tracks integrating discharge planning throughout that process. We pay particular attention to the period of transition you'll note there. This is a time when we know that the patients, especially those with a severe mental illness, will experience some decompensation from their baseline. They may require stabilization, and they're definitely going to require resources to meet basic human needs, as well as medication and continuous psychiatric and medical care. With that, we also know in that period of transition that patients leaving a psychiatric hospital overall have a higher suicide rate than the general population. And we also know that for sex offenders, have an even higher rate, suicide rate, and for those sex offenders who are minor attracted individuals and offenders, that it's even exponentially increased for the risk of suicide. So that becomes an even more critical area of concentration for us to reach that stabilization so that they can actually then begin community reintegration. And we know for our patients on average, they will typically need at least 3 community partners, 3 resource agencies at a minimum, and I think this is true for the prison population as well, to begin to engage in full-on community reintegration. So for us, with those populations, we have patients who have annual reviews, and they can have their terms extended, and we also have individuals who have indeterminate sentences. And some of those patients will get on track to do the preferred step down, which is through the conditional release program, our CONREP program, in which they do receive at that time many of the services that we're talking about. That is part of that step down program. However, the theory disconnects from the reality for us in that many of our patients will secure a legal unconditional discharge before qualifying and entering into the conditional release program. And that's where the SOAR model and those decisions before discharge became a sticking point for us, like, wow, could this really help? And would a decision on SSI, SSDI lead to opening up other decisions before discharge and securing services? And those that we identified, of course, would be community outpatient treatment, and these would be not court-ordered service. There is no court-ordered service, again, for the majority of our patients. So many of them do not have, they have no court-ordered service, and we developed, the social work department works to develop collaborative relationships with community outpatient treatment partners. And of those, certainly County Behavioral Health Access, our forensic assertive community treatment partners, assertive community treatment partners, and full service partnerships become critical for, again, a large majority of the population with severe mental illness. And then we also need to outreach with circles of support, other organizations that assist sex offenders returning to the community, private renters, landlords, and various other community partners, as well as faith-based organizations. Then while we have no court-ordered service is afforded to these patients, we do have legislative mandates that do govern what a discharge should look like. And in California and many other states, we have our Health and Safety Code and our Welfare and Institutions Code, which do set standard for the social work department. We also adhere to accreditation standards and best practice research-driven standards for programs we pilot or implement. And for us, we can look at the Joint Commission accreditation standard requires that a hospital facilitates the discharge or transfer process and helps to ensure that continuity of care, treatment, and services is maintained. And while that seems straightforward, some of that continuity of care, you can't take out that need for basic human needs. Shelter, the access to food, clothing, and the resources that entitlement program benefits such as SSI and SSDI could afford a patient. So all of that's factored in to that overarching standard of that continuity of care and treatment and services that we provide. So for us with the pilot, I actually stumbled onto the SOAR model looking at the SAMHSA web page and started looking through it and was like, wow, this sounds like this could work for our hospital. We were helping patients with SSDI and SSI applications. But what we had been doing was we weren't doing it as proficiently or as systematically. So it varied. There was not the parity going from one social worker to the next necessarily, and we didn't have a system in place in the manual that laid out the steps. So that was something that the SOAR model appeared to offer in a very condensed, easily accessible program. And with that was the basis for the pilot proposal, was looking on that SOAR online course training for case managers, social workers. There was something that, was there, they could go to, they could go through, work on their own time, work with the supervisor. So that was a very big point of interest for the Chief of Social Work here, as well as then looking at how would it move up through the chain of command, and what would be questions and concerns there. So in drafting the pilot proposal, we worked closely with the SOAR TA Center. The experts there helped us along the way. They shared information, connected me with 2 other state hospitals in the country that shared how they implemented it and where it was working, what were some of the challenges they faced. So they paved the way for a fairly smooth construction of a pilot proposal. And that moved through readily. The chief and our clinical administrator could see those benefits, and then going up then became, the issue of rolling it out and talking to the interdisciplinary department chairs, where it might have an impact, certainly with medical staffing and our medical director, because of the medical summary reports, then that, would have a direct impact. So independently, we reached out to each of them and floated the pilot proposal, and they wanted more information. And again, the SOAR TA Center was very instrumental in stepping up and holding 2 different sessions, one for our executive administrators, and went through the process. And also we had a stakeholder committee meeting that brought all of the potential players, and the SOAR TA Center presented and facilitated that, which answered a lot of the questions and, again, paved the road quite smoothly. And we were able to it took about 3 months before the pilot was approved, which is pretty quick. And the bigger questions, I think, that helped to be answered was in having that SOAR model, we could identify and strategically target key staff and put that piece together, what the impact would be on the staff, who would be trained, who would help implement it. So we were able to target that, keep that small, meet the needs of the facility immediately, at least on a pilot level. And again, we were able to screen what patients would directly qualify for the SOAR model and receive that intensive care. So that really helped in linking with that piece with the staff and the valuable resources of our clinicians and staff here. And then moving through that process and implementing it, before I go into how SOAR has helped, I will just say that, again, we had 4 SOAR case managers that were trained. They went through the 20-hour online course training and began rolling this out. And as they had questions, it was a lot of information. Some were new with this. Some were somewhat fearful. This is a federal program. What if I get something wrong? Then they were able to reach out to the SOAR CJ lead, who happens to be myself, as well as to the SOAR TA Center. So again, that really minimized the impact on our supervisors or administrators, knowing that there was a place to go to get information and that this wouldn't cause disruption on the units, to the patients, or stress for the staff. Then how SOAR has helped us at the hospital, we had a minimal relationship with our local Social Security Administrative Field Office, and we had no relationship with our Disability Determination Services Office. Through this process, the pilot inviting them to the stakeholder meeting and working with them, we now have identified liaisons at each of those offices that we work directly with. The applications, the SOAR applications that we submit are flagged as pre-release applications. They go directly to the liaison at the SSA field office. She processes it, enters it. If she has any questions, if there's any flags, overpayments or anything, she works with the SOAR case manager here at the hospital to attempt to resolve those. If some of our patients are poor historians, they don't necessarily remember their Social Security number or remember what benefits they received, it smooths that process. We're able to provide information and indicators that they can access the actual and right Social Security number and get those claims going smoothly. Once they move to DDS, DDS also has a liaison that we work with, and we provide all of the medical record and documentation to the DDS. We used to provide it to our field office, but they were then sending it over to DDS. So for us, it became more streamlined for the three of us to work it out, where we would just send that directly to DDS. And so, I mean, we have just it's a completely different relationship that we have, and it is collaborative, and it is working for, you know, that common goal of reducing rehospitalization, recidivism, homelessness, and just labor that sometimes goes into these prior that went nowhere. Either the field office didn't get it correct from us, we didn't send the right records, we had no relationship with DDS. So now everything with that checklist, it's complete, it's solid, and that has benefited SSA and DDS locally here immensely, because they're just able to move through it quicker, and they know that it's going to be complete. So the increase in pre-discharge SOAR-assisted claims and approvals, well, prior we didn't really keep statistics, so I can't say compared to when we were kind of limping along on our own and just hit or miss randomly trying to get these applications done. But we have had tremendous success. We don't have a large number of discharges at this facility, but the ones that we have, we're in that 80th percentile of approvals on those initial claims. And we have two that are just on the desk to be adjudicated where the patient just has not gone into a local Social Security office yet. But they were favorable, but we don't have. And then a couple of our discharges, they weren't adjudicated by the Social Security Administration prior or within that transition timeline when we stay in communication with the patient or their caregiver, so we don't know the result of that. But the ones that we do know have been phenomenal and of great benefit. And then additionally, the patient funding streams and the basic needs are more easily met, not just on that kind of cursory level that we can say, okay, well, now they have money for housing or food, or maybe they have money for housing, the high cost in California. That may not be so. But how it's helped us is having that piece in place. When we reach out to some of our community partners, we're able to tell them that this application has been done, the date, where it's at, that we have this relationship. Some of our shared living environments, we don't have very many board and cares left in California anymore, but the few that we do have, they can feel more secure in offering that bed that they have available to our patient, knowing that there's no funding in place yet, but that this process has been done. Then they know they're very comfortable to take the patient to their local Social Security office. The case is transferred, and then it can be processed from there. So it definitely has opened up the dialogue where we can offer something. We're not just calling and asking. We have this patient leaving. No, he has nothing. And we can say this is in place. You know, he'll leave with his medications, basics, et cetera. But also there will be this stream that's been initiated that actually has started the application for the SSI, SSDI, for SNAP benefits in California, CalFresh food stamps, as well as our Medi-Cal. And that has just been extremely instrumental for our patient population and also for staff and our clinicians. We all, and I'm sure with all of you, we are invested in the work we do. We believe that in, you know, our ability to assist patients or prisoners, inmates to recover and to reintegrate into society and to hopefully and likely not reoffend or need minimal rehospitalization. If they decompensate, it can be a more minimal stay. If they have that stability and they have some stabilization, then they might need a far less stay at a psychiatric facility than they might without, and additionally, certainly not re-enter the system to find their way back to the state hospital. So for us, we found,
Deborah.
we found the support excellent. Thank you.
For the interest of time, we need to move on to our final presenter and try to have some Q&A to finish some of your thoughts. So we're going to move things along to Michelle from Kansas, who's going to start her presentation.
Hi, everybody. My name is Michelle Cadu, and I'm with the Kansas Department of Corrections. I began as an intern, and I eventually came under the lead of Amy Dean Kampmeyer, who unfortunately can't be here today. She's working on something that just suddenly came up. But I just wanted to let you know about some information that she put together regarding the SOAR program that has been relatively impactful for several reasons, and numerous offenders have gone out into the community and they're flourishing, and the number of people that have actually come back has actually been reduced. And these are some of the things that they had to consider, what they were going to do, how are they going to try to get people to that type of finish line. And the first thing that they had to talk about was logistics. They had to talk about what the facilities really need, where are the offenders housed that have the most need, where is the behavioral health and medical population going to process out of, do we have the staffing to take care of this program, do we have a need, what is the exact need. And at this point in 2019, there were 40% of the offenders in our population that have been diagnosed with mental illness, so definitely the need is there. And the last thing that was going to define whether or not this program was going to work was getting the support of management. Now, at first, people didn't understand. They didn't know what the end result would look like. They didn't know what the details would include. So it was kind of difficult to get this started off, get it up and running. But once everything came together, you had the management support, facilities understand the need and the process of the program. We had people in place, and we also developed collaborative partnerships with people in the community, and their resources are very appreciated, and the people go above and beyond everything that anybody would expect someone to do. Then the next area that we had to focus on was in 2016, the slide on the left, the circle on the left, shows you the number of applications that we submitted, and they're broken down by percentage of the outcome. Initially, when this was all implemented, we had a total of about 12 discharge planners who were SOAR certified, and the idea was that every facility would have one SOAR certified person, and those individuals would submit the applications for the people in those facilities. Well, when this first started, the approval rate was 51%, denied was 47%, and then, of course, they had the 2% pending. But eventually, that particular model faded away because it turned out that the discharge planners were already overtasked and didn't have the time to devote to the SOAR process to get to thoroughly understand and recognize all the steps that are involved with submitting a SOAR application. So it kind of took away from their overall purpose. So along the way, an individual was identified to become a dedicated SOAR specialist, and that particular person came on board 2017, and this slide with the circle on the right represents the outcomes once we had a dedicated SOAR specialist. The approval rates went from 51% to 75%. The denieds show a percentage of 3%, and this model continues to work for our facilities. We do have a couple people on staff who do still submit SOAR applications, but the numbers are pretty minimal, but they still continue to take care of the offenders that we have. Now, once I came on board, I am actually the individualized dedicated SOAR specialist, but I actually help oversee any of the facilities in the state that need help with any of their applications. They might have somebody that get identified that they think needs some help. I'll come in and we'll kind of go through the vetting process with somebody. Once we go through all the steps of making sure that this person is going to be an acceptable SOAR candidate, then these are the steps that I will take in order to get the application up and running. First of all, we've got 8 facilities across the state. I have to familiarize myself with the setting, the rules, the schedules of each facility. I don't want to intrude and don't want to interrupt offender schedules. They are very meticulous, and they look forward to different parts of their day, and I try not to interfere with that activity if at all possible. And then I make sure I review the individual's intake documentation, their criminal history, their past, and maybe the most recent infraction. I also make sure I understand their medical status, their diagnosis, and whether or not they're on medication and are they compliant. And then I also have to make sure I have all the proper supplies. Once you get inside the facility, each of them vary. You're going to get maximum security prisons. You're going to get facilities where the offenders may come to the office, so you just kind of familiarize yourself with where you're going to be, but you always have to be prepared. And I cannot count the number of times when I ran out of paper because somebody was such a good interviewer, or my pen ran out of ink, so I'm always going to make sure I have the right supplies. It seems simple enough, but it's very important. Another thing, that once you enter the facility, you should always make sure that you engage, observe, listen, and record. As soon as you get to that facility, you're going to need to start paying attention to everything that's going on around you, all the activity. You need to get to know the individual, the offender that you're going to speak with. You got to build up a good rapport with that person so they're comfortable. You need to get to know the staff, and then you also, like I said before, need to know the environment. And then once you start engaging with that offender, you need to be able to ask them questions so that they're not just going to sit there and say yes or no, give you a date. You kind of want them to engage in a conversation, if at all possible. Now, sometimes there are going to be times when somebody may repeat themselves, or they might give you an actual factual statement, but then it kind of meanders and becomes like part of some kind of delusional thinking. And then at that point, if you notice that there's a pattern where this continues, then you're going to want to make sure you recognize that pattern and kind of bring them back to where you need to be in the interview. And then always collect as many quotes as possible, because keep in mind, DDS is not going to see these people. And I, in fact, don't even know if I'm even going to get to see these individuals again, because based on whether or not they go into crisis placement, whether or not they get moved to another facility, or whether or not they'll be accessible. So you've always got to make sure you let them do a lot of the explaining. You want them to provide as much detail as they possibly can. And then you're going to want to combine all that information from the interviews into your MSR. You would like to have that be a representation of that individual. Like we always say, you need to be able to tell them that we're painting a picture of them for the DDS so that the examiner gets an idea of what this person looks like, what they sound like, and their rational and thinking that they might use during the interview is going to be all part of the process. And this information also gets applied when you're doing the MSR. You're going to have medical records that help back up the diagnosis. And for Social Security, you're going to want to make sure you refer to the SSA Blue Book listings for the particular diagnosis that you're working with. Now, a lot of the sections for each diagnosis will tell you you need medical documentation that shows one or more of the following, and that's usually in a Part A section. And then there's a Part B, which is called the extreme limitations that these individuals might show, which is the functional information. And I've listed them below where they say understand, remember, or apply information, interact with others, and so forth. And in those areas, you're going to want to observe the offender in your environment, in the records that you've developed or kept or created for them. And you want to make sure that you can pull out as many details as you can and back that up with any kind of data. And it's kind of difficult to translate some of the behaviors into those 4 categories because you think, okay, they're incarcerated, it's a highly secure area, are their behaviors the same or different than when they're out in the community? And most times they are. But once they get inside, you know, behind the facility, within the facility, they do develop their own behaviors and patterns. And so you are able to draw that out in each instance. So you're able to kind of talk with them about these different scenarios that I've listed on the behavior translations. So like, first of all, you're going to talk about the mental and medical history that somebody has. You're going to want to know, do they have insight? Do they know their diagnosis? Do they know the medication? Do they know what triggers them? And are they in compliance with treatment and or medication? Now, that particular category will show you, you use that for the 3 categories: understand, remember, or apply information, interact with others, adapt or manage oneself. Now, you could possibly try to figure that it could go into the second category as well, but the 3 areas that I mentioned are the ones that I typically focus on. And then the next one is whether or not they're able to communicate. How is their memory? Do they advocate for themselves? Can this person read or write? Can they speak? Can they provide background information accurately? Can this person apply program information that they've learned to everyday interactions? And can this person seek help or ask for help? And then that particular item would actually apply to understand, remember, or apply information, and I've also used it for adapt or manage oneself. The next item is program participation, complete tasks. Does this person participate in any programs that might help them increase the likelihood of getting out earlier for good time? Does this person attend those sessions? Do they leave early? Do they participate? Do they get upset? Is there somebody in the group that they don't like? Whatever reason, you need to verify what happens when they attend these particular sessions. And then also, can this person complete forms? Can they ask for help when they need help with the forms? And then can they follow directions? And that particular one, I would say, applies to all 3 of the items: understand, remember, or apply information, concentrate, persist, or maintain pace, or adapt or manage oneself. The next one is socialize, relationships, and boundaries. And this is pretty important, and I say that kind of coincides with whether or not they're able to understand, remember, or apply information or interact with others. We want to know, does this person socialize, or do they isolate? Do they stay in their cell? Do they connect with individuals in the community? Do they have the support of loved ones? And then also, does this person recognize facility boundaries, whether it's social or physical? The next one, appropriate hobbies, interests, and activities. Can this person occupy their spare time with appropriate activities? Like, can they watch TV shows? Can they watch them all the way through? Do they watch movies? Can they see those all the way through, or do they get distracted and turn the channel or walk away? Do they read? Do they play card games? Do they do puzzles, draw, paint, write, or do they do art? And then you've got to make sure that those are appropriate activities. I think there are people that will do art and maybe write that kind of sometimes get themselves in trouble, which is also not going to be well accepted. So we'll put that particular category in concentrate, persist, or maintain pace, interact with others, adapt or manage oneself. And then the next item, personal hygiene and cell cleanliness. And it seems like that would be pretty much understood, but there are levels to which someone may or may not conform once they're in the facility. Some of them are not able to take care of their cells, getting rid of trash. Most of the offenders will even take the mattress and just sleep on the floor, may not even use a blanket. So you kind of want to notice those things when you're interviewing them. And then another thing is sometimes some of the offenders will be subject to taking forced showers because they refuse to do it on their own when they're asked to get ready and prepare for that. They just don't want to do it. So that one will go with the adapt or manage oneself category. The next one is special housing needs. Do they need a security escort? That is coinciding with interact with others, adapt or manage oneself. We need to know, is this person in the mental health cell? Are they in restrictive housing? And then we also need to know why they're in those particular areas. Can they function with other cellmates? Are they a danger to themselves or others? And then you come across several offenders who say they're more comfortable being behind bars than out on the streets. They've developed this institutional behavior, way of thinking. They relied on the system. It's maybe something they're familiar with since they were in middle school and went to juvenile detention centers. So some offenders kind of feel like they know they're more comfortable with navigating that type of system. They've never maybe lived on their own in the community. They are homeless when they're out on the streets, and then they maybe have never worked or they don't know how to find work. And then the last one is disciplinary reports. Now, this is a big one. That one will particularly go with all 4 categories because a disciplinary report means that somebody has acted out, they violated a policy, they end up racking up fines, they lose good time, they lose privileges. But not only that, I mean, that's just on the forefront, that's what you initially see. But when you get to talk to the offender, you get to ask them why. Why did that happen? Why did you throw that bottle? What did that person say? And then maybe it's a repeated behavior they've done with this person. So it's good to get to the bare essence of why they actually acted out the way they did. And then is this something they would do again? Is it something that could have been avoided? And then also the disciplinary actions could also be ranked in severity categories, meaning 1, 2, or 3, and 1 being the highest. Does this person mostly break class 1 violations, or is this person mostly getting in trouble for level 3 kind of issues? So we kind of look at that as well. And then we also look at whether or not this person is acting out towards staff, other cellmates, or just other offenders in general. So that is all the kind of information that we look for to put into those 4 categories on the MSR. And then really the MSR limitations those are the areas that are going to carry your MSR and give the support that you need, where you can actually play with the data, get everything confirmed and validated and submitted in a numeric substantial form that cannot be disputed. If you have the actual numbers and not just something that's based on a subjective opinion, that'll have more weight when they're making their decision. So this is something we've kind of developed over time as we've gone. There was no floor plan or no map to follow. We just kind of had to navigate and figure this is how we're going to evaluate. So
Great.
At this point,
Michelle,
I think I am finished.
Yeah, thank you so much, Michelle. I think ending with how you write your MSR and conveying the functional limitations as they relate to the impairments is really, really helpful. So in the interest of time, we really only have a few minutes left for questions. And I assure you that the questions that have come in, we will be sure to answer those offline. You have the email addresses for all of the panelists today, so feel free to shoot an email out if you didn't get a chance to pose your question in the Q&A box. You're welcome to email our panelists. We had many questions come in about the basics of SOAR, how to get trained. So we really encourage you to check out the SOAR website at soarworks.prainc.com. And also questions about how to get in touch with your SOAR local leads and your liaison. So you want to go to the SOAR Works webpage and click on your state, find out who your leads are and your TA Center liaison, and we'd be happy to help you work out any collaborations that you want to develop with SSA. If there's any online course training cohorts in your area, we'd be so happy to give you that information to guide you along. But we did have a couple questions that came in for Deborah because, again, you've developed your pilot project. So, Deborah, can you talk a little bit about when you presented this to your executives at the state hospital, any concerns or questions that they had for you? And if you can just give us a really quick, kind of wrap up of how the pilot is going so far. in 1 minute or less. And you may want to unmute yourself too. Okay, sounds like Deborah may not be able to hear us right now, but we did get some questions that came in about, maybe before the panelists got a chance to cover that on their slide, like, you know, can an applicant apply for SSI while they're incarcerated? Can they apply while they're incarcerated? So those questions hopefully were answered. If not, we will still follow up with you and encourage you to check the resources that Dazra did share with you. It has some great information about SSI and SSDI and how it is impacted by incarceration. So we are coming to the end. So I just want to encourage all of you to familiarize yourself with the SOAR and criminal justice tools that were shared. Contact your liaison with any questions. Take the online course if you haven't already done so. And if you are completing SOAR-assisted claims, to put your outcomes in OAT, as Dazra talked about earlier. So I want to take this time to thank all of our presenters, including Amy, who could not actually present her slides. We thank you. And at the conclusion of the webinar, you will be directed to an evaluation. So you'll get this email alert, to the external site. You need to click continue. We really encourage you to take that evaluation. We appreciate that. And again, please get in touch with us, and again, have a great rest of your day. Bye-bye.